Hello, this is Dr. Antherica Lane with Conversations with Dr. Lane. Thank you for joining my show. Today, I am talking with Dr. Odell Owens. Dr. Odell Owens is a great Cincinnatian. He is a leader in reproductive and infertility medicine and a servant leader. He is a fascinating person with an interesting perspective on a variety of topics. My show today is actually part two of a conversation that I had with Dr. Odell Owens. For part one, please go to my YouTube channel at Lane Media and Photography and search for the Cincinnati Medical Association Medical Report interview with Dr. Odell Owens. We're going to get right to the show. Please remember to subscribe to my channel for notifications of future shows. Here we go. Hello, this is Dr. Antherica Lane with Conversations with Dr. Lane. We are so excited today to have a very special guest, Dr. Odell Owens. Dr. Odell Owens is the President, Chief Executive Officer, and a board member of Interact for Health and Interact for Change. He joined Interact as president in October 2016. Dr. Owens holds both an MD and a Master's of Public Health from Yale University Medical School, where he also completed a residency in obstetrics and gynecology. Dr. Owens completed a fellowship in reproductive endocrinology at Harvard Medical School and served as a clinical instructor in reproductive endocrinology. After returning to his native Cincinnati in 1982, Owens established an in vitro fertilization program at the University of Cincinnati Medical Center. He achieved Cincinnati's first successful conception and delivery, as well as the first pregnancy from a frozen embryo. In recent years, Dr. Owens has served as the Hamilton County Coroner, Cincinnati State Technical and Community College President, and Medical Director, Interim Health Commissioner of the Cincinnati Health Department. Dr. Owens has also served as a member of the board of directors of numerous organizations, including U.S. Bank and the National Underground Railroad Freedom Center. It is such a pleasure to have Dr. Owens with us today. Dr. Owens, we're going to get right to our questions for you today. African American physicians continue to remain a small percentage of the total physician workforce in the United States. According to the American Association of American Medical Colleges, African American physicians comprise 5% of the active physician workforce. Why is it important to diversify the student populations within medical schools across the country?
Well, when you look at medical school as well as any other, I think, graduate program or profession, you want some diversity because you want people who can bring their historical perspective to the table. And part of that historical perspective in medicine is understanding the community, understanding the economic issues, the language, some of the myths in a health community. And certainly 5% is not enough of representation when African Americans are close to almost 15% of the population. That isn't to say that a white person can't take up a black patient or a black doctor can't take care of a white patient, but there are times when your historical perspective and the brownness of your skin is part of the art of medicine. There is the science, but there's the art of medicine. And that art of medicine is being able to get a complete history from a patient, having that patient have trust in you, but more importantly, trust in what you're prescribing or what you're asking them to do.
How has the status of African American physicians changed over the past 50 years, specifically in Cincinnati, Ohio? I know you are from this area. Do you believe that we have made progress?
Well, I think we made progress on a couple levels, and then I think we still are far behind. When I was a college student, the college that you just said, the American College, I guess, of Medical Schools, I think at that time might have been called, they said, we're going to set a goal they wanted to set a goal of getting, I think at one point, 15% of medical students to be of color. I don't think they used African American. It may have said Negro at that time. But over the next 7 to 10 years, it moved from minority, kind of moved from minority, talking just about African Americans, to any group that wasn't white. So we got diluted very early on. They never reached the goal that they set back in the 60s. Never reached the goal because the minority got diluted into what people were put into that group, and including sometimes even women as a group were put in, black or white. I think where I see the first real progress in our society here in Cincinnati, very conservative Cincinnati, is that black physicians can take care of white patients. Now, that may sound very odd, but you have to realize that just when I started practice here in 1982, I was the first reproductive endocrinologist to practice, Harvard, Yale trained, given the award as the best chief resident at Yale, first African American to do a fellowship at Harvard. I had all the accolades, extremely well trained. I could do surgical procedures that no one else in Cincinnati could do. Yet, whites would walk in my office and turn around when they saw that I was black and walked out. I even had patients say to me, when I got them pregnant and it was their last visit, they would say they felt so guilty because they said, when I first walked in and saw you were black, I was going to walk out. But I felt that you probably were my last hope. So we had that transition where whites wouldn't feel comfortable coming to a black doctor, especially in gynecology. That was the most sensitive and probably one of the last residencies where African American males in the best training programs could enter. So I think you've seen a transition now where people recognize quality and people are willing to go to a doctor, black or white, based on the quality care they're going to get. I think that's tremendous when you consider where I started in 82 and people would parade in and walk out when they saw that I was black. What changed that was certainly you start getting a number of people pregnant who had been told they could never get pregnant. I was fortunate enough to be asked to be on various TV programs. Sally Jesse Raphael, I was her on-air gynecologist for 2 years. And certainly that totally opened the door because Sally would say, I hate doctors, but I love this man. And that, boy, my door just wide open in a time period in very conservative Cincinnati where whites were uncomfortable seeing a black doctor. So we made that level, but we haven't made the level in terms of having African Americans across all the subspecialties. We don't have enough family physicians. We don't have enough internists, and we should. In the city, there's 40% African American. We need to have people, as I said, who understand the total patient and who can use that art in collaboration with the science of medicine to give that patient the best care when other people may dismiss them or not understand some of their issues or their language.
Let's talk a little bit about residency. Residency training is probably one of the most difficult time during many physicians' journey to their particular specialty, and particularly for African Americans. And I can personally remember being called dogmatic when I was simply being confident or being articulate about a perspective. And not being called dogmatic as a compliment, but as a sense of maybe you're just a little too confident. And so it's a very different experience as an African American female when you're training to be trained in an environment where the goal is not to edify you and lift you up, but in many ways it's to basically keep you in your place. And
Right.
that can be very difficult for educated African Americans. What
Well,
words of encouragement or what's your perspective on that?
well, again, I went to Yale, started out Yale in 1971. Yale class was historically 100 medical students, very small compared to most medical schools. Um, and we had 7 African Americans in our class, and that was one of the larger classes for African Americans. So when we were there was certainly, we certainly got that sense that people looked at us and wondered if we were here because we were smart or we were here because we were black. And certainly that impedes your ability to feel at home, to feel that you're going to be part of a team and that people are going to teach you and that you're worthwhile teaching. I took on a different philosophy. One of the things that I did, I went and registered for a master's degree in public health. So I did my master's degree at the same time I was in medical school. So my philosophy was then, okay, if I'm raggedy, if my education is raggedy, then how can I handle both of your degrees at the same time? Either your stuff is raggedy or I'm raggedy. You tell me, either I'm qualified or your stuff is raggedy, that I can do two at the same time. Plus, I was president of my class, captain of the medical school basketball team, and I was a member of the board of trustees of Antioch College. Now you tell me if I'm qualified or not. But however, even with that, I had to set my professors up in that as an African American student, I could never go to bed without reading my list. And in those days, the list was you heard about a disease or medication, you looked it up before you went to bed. White kids could do that. We couldn't because we knew they're going to come back and ask us. So what I did, I went and get the British textbooks of medicine. And I would find things in the British textbook and throw it out at rounds, and I would get challenged. So, but what I did, I would feign like I was, that I had extra sensory perception, and I would quote the page number, the paragraph, and the sentence. The professor would send someone to the medical library to get the book. They bring it back. So after a while, they said, "Hey, leave it alone. Don't mess with that because he will embarrass you." But it made me a better doctor. When they were challenging me, and you know what rounds were like. Oftentimes if I had a patient, I was expected to know my patient. But for the African American students, oftentimes we were asked about someone else's patient or another medical student's disease that his patient had. So we had to be on our toes. So while they thought they were busting us, you made me better. So like you, in a way, I took on a position of bring it. I was in medical school was bring it. I'm going to be prepared. I'm not going to relax. You bring it. I'm ready for it. And so I had another classmate that in another class was probably the best student in the class, but couldn't handle that pressure and eventually kind of flipped out at the end, but was probably the best student in the class. That's why how you handle that pressure. My thing is, hey, be confident. Be confident. Know your stuff, but back it up. Now, I read and I backed it up.
Right. I think you're leading me to my next question, which is a very valuable lesson about how to compete in this environment. As a business owner, I've been really somewhat disappointed in regards to the pool of candidates that may come for a job position. And I think, wow, what about your computer skills, your ability to express yourself, your ability to uh, explain your story, how you got to this point. How are African Americans going to be able to compete in a professional environment? What is it going to take for African Americans to compete in a professional environment?
Well, we got to do our homework. And as always, we got to do a little more. I just finished 29 years on the board of trustees of U.S. Bank, which is the fifth largest financial institution in the country. So obviously a physician being on the bank board is not your common thing. I'm probably one of the few physicians to be, and maybe the only physician on a major bank board in this country. But I did my homework, like other directors who were CEOs of some of the major corporations in this country. I went to courses. I went to the educational courses that were offered and to seminars. So I had to learn a little bit more because of being a physician, but I also learned more about the banking and didn't take it for granted. So while they were silent doing presentations, I could participate with the management team because I did my homework. So we got to do a little extra, and we've always had to do that. So that's not new. But I think when you're a professional and you're trying to hire other people, I think sometimes you got to decide: do you want someone who's skilled, or is that a skill you can teach them? Do you start with that personality, that work habit? When I had my private practice, I had probably at one time hired at least 12 people, and I was in single practice. But I would hire people, and what I would do when I interview people, I would pay them to come and work a half day at my office. I put them to work, and I paid them. That was the interview. So my staff get to interact with them. The staff can say, "Yep, they know this stuff." No, they don't really know this stuff. They inflated their resume. They can't work this machine. They can't do the billing. They don't know how to do the cleaning. So I found that was really valuable for me to be willing to make that investment for a half a day. It wasn't very much money, but it gave me a chance and the staff a chance to see if that person was going to contribute to our office.
I've actually taken that approach as well of investing in people and really mentoring them through this
Yes,
process because some people you do see their potential
yes,
and you just think, oh, if they just had an opportunity, and sometimes just that one person is all it takes to give them that opportunity. Well, Dr. Owens, I could talk to you all day. Thank you so much for your time. Thank you so much for your insight. This has been an absolute blessing. This has been Dr. Lane with Conversations with Dr. Lane.